Zach, summarize for us, if you would, what we know about misophonia treatment.
Okay, what do we know about misophonia treatment? Well, the one thing we should start with that we know is that we don't know. We don't know that there's one thing that works for everyone. And I really appreciated what Dr. Gregory said earlier today, that we clinicians, we should hope that clinicians and we who are clinicians should strive to be humble and let go of our assumptions, let go of our biases, let go of our expectations about other disorders being the same as misophonia. I think that's a really important thing. So the takeaway there for this first piece is we don't have an answer. There is no cookie cutter treatment for everyone. There just isn't. There just isn't. There are a few research studies that have begun looking at treatments for misophonia, but very, very few. Research studies that are treatment studies are long, they're really expensive. So there's just not been very many of them. And the few that there have been mostly focused around cognitive behavioral therapies. As you heard Dr. Gregory in her presentation, cognitive behavioral therapies really represent kind of an umbrella term for a lot of different specific interventions, not one particular technique. So when we think about what seems most promising based on what the available, very limited science shows us, it kind of skews us towards cognitive behavioral therapies, but that's not that helpful in some ways because it's not a particular specific treatment. And there's only one randomized trial. There's only one trial that's been published that's a randomized trial comparing any treatment to a control condition for misophonia. And that randomized trial was a group therapy done by the terrific research team in Amsterdam. They did a group therapy, a very brief group therapy for patients with misophonia. It's about 8 sessions long, 3 hours per session, and it had multiple different components in the group therapy. But essentially, it's a cognitive behavioral therapy type of group. And they showed that compared to a waitlist control, there was some improvement. This is a first very small randomized trial. And again, the takeaway here is we really don't know. Cognitive behavioral therapies broadly have been studied in the field of clinical psychology as treatment approaches, in general, more than a lot of other treatment approaches. And so it sort of stands to reason in a lot of ways that a lot of first low-hanging fruit efforts to try to understand which types of treatments might work for misophonia, that they might come from the cognitive behavioral therapies literature. It's just a bit more advanced. There's literally decades of research using various, many different CBT interventions. And some of them are branded, with brands and acronyms and manuals that are kind of rigid and sequential, and others are not. They're really more flexible and more principle-based, more like what Dr. Gregory, who's now joined us, more like what she was describing in terms of being creative and flexible and tailoring the treatment. So the other thing I'll say to try to be quick here is that what we recommend at Duke for a starting point is really a multidisciplinary framework. I'm a clinical psychologist, but I don't think we should think of misophonia as something that should always be just treated by a clinical psychologist. I think there's just not enough reason scientifically to think that, nor is there reason to think clinically that that is the right way to go. With so much variability in what misophonia can look like in any given person, and with many different disciplines, including audiology, with Dr. Campbell here representing audiology, there's various disciplines that I think need to come to the table to help any given person understand what will work best for them with misophonia. I'll stop there.
Thank you, Zach. And Dr. Campbell, Dr. Gregory, thank you both for being here. And one of the reasons that we wanted you both here together is exactly what Zach just said, which is misophonia, we think, is best treated in a multidisciplinary, interdisciplinary manner. So that out, Dr. Gregory, talk about maybe how you can integrate your work with an audiologist, whether it's, again, clinical, in a clinical setting or in a research setting. Well, hopefully Dr. Campbell gets her mic on.
Yeah. So the main interaction that I've had so far with audiologists has been in terms of presenting research. So when I've in the UK done research presentations, I've had an audiologist, Hashir Az, who does a lot of work on misophonia here in the UK, presenting in the symposium with me so that people can hear a perspective from an audiologist. But what's really interesting is that what Hashir is doing is audiology delivered CBT.
Mm-hmm.
And so what I've been also doing is reaching out to some other audiologists to hear a bit more about what else people do alongside CBT to help. And I know that there are some audiologists working with sort of sound devices and things like that. And I think that from my perspective, so what I'm interested in is how can we help people to function as well as possible, as quickly as possible. And so I think one of the areas where joining forces with audiology and psychology is, especially in those early days, is what's going to help now. What can we do to reduce the overall burden of misophonia so that the nervous system can have a little break, people can start living their lives again, and that might be sound devices to sort of block out a bit white noise, to block out other sounds, that kind of thing. And then when they're feeling a little bit better and functioning a little bit better, then we look at, okay, now what are the psychological aspects that we want to work on that we think will lead to lasting changes over time?
Thank you. Zach,
I'll add to that, since I regularly refer patients in new patient evaluations for audiologic evaluations. I think that for me, what comes to mind first is to screen and to rule out any kinds of other audiologic conditions for which me or Jane, we're not the people, we're not qualified, we're psychologists. So to be able to assess and rule out something like a hyperacusis or a phonophobia, to look at central auditory processing problems, to help assess whether there is a kind of super sensitivity, if you will, that is measurable in that person. And so that's a starting point, is just to kind of get a handle on those things up front. In my opinion, it's not a referral to necessarily start treatment right away. It's really a referral to get an evaluation that's more multidisciplinary, if possible. What can come from that I think are really helpful in my experience as a clinician with patients after they've seen the audiologist, sometimes a letter of accommodation can be helpful when it's got testing evaluations that are supportive of particular accommodations, whether that's at work or whether that's at school. That's something that an audiologist can, in some situations, provide. It's really helpful for people, very empowering for people. The other thing is that sometimes they'll provide, as Jane was talking about, they'll provide kind of recommendations, education, and options around how to use listening-based kinds of interventions to help with coping strategies. I don't know if Dr. Lisa Fox-Thomas is still here. I saw her name earlier in the participant list. She's a person who I regularly kind of coordinate collaborative care with here in North Carolina. And I've had patients that have gone to see her who have chosen not to do the evaluation, who have chosen not to do a kind of a sound-based intervention. I've had patients who've tried and have said, wasn't so helpful. And they had others who've tried and said, wow, Zach, that was really helpful. Thanks for sending me to her. She helped me figure out how to use these devices. And they enable me to be able, in some circumstances, to be around my loved ones when they would otherwise be triggering me. And no, it's not the only coping strategy, and no one should never, only rely on that and become too dependent on it. But it might be helpful for some people in some cases.
Thank you. You're back, Dr. Campbell. Welcome back. Is your mic working?
I don't know. Is it?
Yes. Okay. Very good. All right. So I'm sure you are probably very stressed out right now, but if you could maybe comment a little bit, and this is to some degree what Zach was just doing, on what kind of auditory disorders should be ruled in, should be ruled out, and how should either a parent or a person with misophonia go about getting this done?
That's a great question. The first thing that should be done is have a full audiologic markup. So you want to go to an audiologist for this. I would recommend seeing if any of your local audiologists specialize in sound tolerance disorders. Misophonia falls under this, or if they have experience with tinnitus, which is a highly comorbid disorder. So those are the first things to check. And what we're going to look at is, does the patient have hearing loss? Are they reporting sensitivity to the volume of sound or just the type of sound itself, or a combination? Do they report tinnitus or ringing in their ears? If they have all three. And so usually what we see in individuals with misophonia is normal hearing. So hearing loss, it doesn't tend to be prevalent, but it happens. And that can be a separate issue or related. I know Dr. Oz has done some really great studies looking at the relationship between hearing thresholds and misophonia and seeing if there's any relationship. We don't tend to see a relationship with hearing loss, like I said before. Let's see, what else was I going to say? We also are going to give questionnaires that are specific to tinnitus, hyperacusis, or sensitivity to the volume of sound, and misophonia. And what we're trying to see or titrate is misophonia present with these other sound tolerance disorders, or is it independent? And I think a big kind of controversy in audiology right now is whether or not misophonia is a standalone disorder or is it a subtype disorder of hyperacusis. Mm-hmm. And that, again, like I said, it's a controversy and there's clear sides on that controversy. My opinion is that if we see indicators of hyperacusis being present in somebody who is reporting misophonic symptoms, then yes, misophonia is probably a subtype of hyperacusis. But if hyperacusis is not present in that individual, misophonia should be a standalone diagnosis. And unfortunately, I think that's all the detail we're able to do currently in the clinic in terms of diagnosis. But we need all of this information to get a holistic picture of the patient, determine hearing aids might be helpful if they have hearing loss and misophonia. That might introduce some sound stimulation into the nervous system that's been missing that could potentially affect this perception, this atypical perception. Would sound generators be helpful in combination with therapy? I think I caught the tail end of Zach talking about this, but tinnitus retraining therapy also addresses hyperacusis and misophonia. I've used it one time in a patient with misophonia symptoms, and basically it combines some therapy, some understanding of the disorder as well, some teaching that individual about the disorder with sound therapy. And that sound therapy can be very different and tailored to the individual. And it worked great for them. They report having no issues anymore. So I think Zach's answer was really apt in that there's going to be different therapies for different individuals. I'm hopeful in the future in looking at diagnostics that we will be able to perform some assessments and say, okay, you're meant for this treatment. You're meant for this treatment. And do evidence-based treatment in that fashion.
Thank you. And we have a question. Thank you very much. Not really a treatment question, but maybe I can turn it into a treatment question. Since there is no universal cure for misophonia, what are all of your thoughts and experiences with adapting the environment? I think that's a great question, actually. Dr. Gregory?
Yeah, I think that have multiple opinions. I'm going to try and contain them. So I think it's really important to have safe spaces. So you need somewhere that you can go where you know that you're going to be okay. And I think that that's probably the most vital thing, is just having a space that you can go to, so that if you do venture out into loud, noisy, annoying spaces, you've got somewhere you can go back to. So I think that that's the thing that I help people to prioritize, is to make sure that they've got that space. The other part is about making sure that people can function. And for me with therapy, the patient's goal is the most important thing. So do they just want to be able to go to work and get their work done? If so, then accommodations in the workplace might be the only thing we need to do, because that is their priority. But it's also once we get into that realm, creating spaces that are friendly for misophonia, they can be unfriendly for other people. I was horrified to discover there was a research study that found that chewing gum reduces anxiety and improves test scores for some people. I thought, this is horrible news for people with misophonia. And so we can't create these universal environments that are accessible to everyone. But what we can do is communicate who the environments are accessible to and what sort of adjustments the individuals might need to make within those environments.
That's such a great answer. Dr. Rosenthal, do you want to also answer that?
I have very little to add. I agree with 100% of that. The only thing I would maybe add to this is that I think oftentimes what we see is that people sometimes fall into extremes of either thinking that they need to tolerate it all themselves, or in the case of parents, that the child should tolerate it all, or on the other hand, that the accommodations need to be made by the rest of the world for them. And I think there's a dialectic here. I really do. I think there's sort of a dialectic of accommodations, that on the one hand, the extreme is the world accommodates me entirely, and the other hand is that I accommodate the world entirely. And I think neither of those extremes are helpful. And it's just supporting what Dr. Gregory was just describing. It really needs to be figured out for each person in the weeds of their goals and their values and what they're looking for, and their family and their context, exactly what might be most effective, most pragmatically effective to kind of maneuver and manipulate, which context needs to be shifted in which ways, so that there's not this tendency to kind of be on one side or the other of that dialectic.
Absolutely. Okay. I don't think we have any, at least, questions that I'm seeing here in the chat. Is there anything that any of you would like to add, especially Dr. Campbell, since you had so much trouble getting in? Is there anything that you can add? No, that's not your fault.
In just looking at the chat, there is one thing from an audiological standpoint I would recommend not doing that I know I'm going to get a lot of pushback about, and that is wearing earplugs or headphones consistently. We have research in our field that shows that doing that introduces a false hearing loss to the central nervous system, and that's going to cause other issues, including brain reorganization, to kind of compensate for that false hearing loss. And so I strongly recommend not taking that approach. However, I completely understand having to do what you have to do to function. But that is something that I would just like everyone to be aware of, that can cause an exacerbation of symptoms and, again, brain reorganization that you wouldn't necessarily want.
Dr. Campbell, along those lines, is there any way to quantify that? Are there a certain amount of hours in the day that, if a parent asks you, or, how much can I allow my child to wear headphones or earplugs, like realistically? Is there something quantifiable?
That's a great question. I don't think it's quantifiable across the board. I do think it would have to be hours to cause these systemic changes that we see. So I think, an hour or two a day of having headphones on or earplugs in is not going to be problematic. But I'm talking several hours usage, we might start to see some of those unwanted effects.
I just want to add something to that, because I think one of the things that's really important with all coping strategies is to constantly reevaluate them and to test them out in different contexts, because you might discover that you don't need a coping strategy in one situation, or that you cope better than you thought you could. And it's really good just to be really curious about your misophonia and to assume that it will be varying with time, and just to test things out every now and then to see how things are for you and how you're doing with your misophonia. And if you end up doing exactly the same thing that you've been doing, that's fine too, but at least you know consciously that that's a good choice for you for that moment. And being in control of that is a really important part of it, because so much of one of the layers that I talked about in my talk of misophonia is not being in control. And by testing it out for yourself, you are putting yourself in control, because you're making a conscious choice to either try or not try a particular coping strategy.
Thank you. One other question that someone has asked twice is hypnotism, is there any validity to this as a therapy for misophonia?
I went ahead and answered that in the chat.
You did? Okay.
From just from my own experience, I have not had patients who have reported that it's been helpful. But of course, the logic is that the patients who would have found it really helpful probably wouldn't have reached out to me for care. So it's unknown.
I'll say the same. We often get people who have tried and it hasn't been helpful for them. And unfortunately, the key thing is with all this is the research just isn't there. And I know there are some groups of people who are using hypnotherapy as a treatment, but unfortunately what we don't have is the results of all of the people that go through their service. What tends to happen is we see the results of the people who stick with the treatment, and we know that the people who stick with treatment are the ones who are most likely to be benefiting from it. So what we need is somebody to be monitoring the outcomes from those services to see what happens to all of the people that come through the service.
One other question about, I guess for Dr. Campbell, are there any issues with using white noise all the time or pink noise versus, headphones that are concealed?
That shouldn't be an issue, because that's not causing a deficit in stimulation to the auditory nervous system. What we see is when you deprive your nervous system of sound, or really any sense, that's when we start to see these reorganization effects. And so if you're stimulating the system, I wouldn't expect to have the same negative impacts.
We're at time. I don't know if we want to take any additional questions to the wrap-up Q&A that's in the next session. This has been really helpful. Thank you all.